In this lecture, we will be discussing AV blocks. The objectives: we're going to identify the EKG characteristics of atrioventricular conduction defects, the hemodynamics consequences of atrioventricular conduction defects, and describe the clinical management for those patients with atrioventricular conduction defects. The focus now is back on the conduction system. The disturbance with this conduction is that the impulse is coming from the SA node. And again, it usually will go down the AV node into the bundles of His. However, the impulse that is generated through the AV node is either delayed or blocked. So this is not a problem with the SA node, this is a problem with the AV node. The delayed or failed conduction may be temporary or permanent. This may cause lengthened PR intervals or more Ps than QRSs. The AV blocks are classified according to their severity and site. First degree AV block is the least severe of all the AV blocks. All electrical impulses are conducted to the ventricles. But what is happening is they are delayed by the AV node longer than normal. So the rhythm is essentially normal sinus rhythm, but it has a prolonged PR interval. Remember, your normal PR interval is 0.12 to 0.20. So the PRI would be prolonged, greater than 0.20 seconds. The one other thing to remember is that all the PR intervals are constant, meaning that they are the same. If you were just looking at this rhythm, you would look at it quickly and you may not notice that there is a first degree AV block. That's why it's very important when doing your rhythm analysis that you don't skip a step. So you identify that the rhythm is regular. You would determine what the rate is. You note that there are P waves and there's a P for every QRS. If you do not measure the PR interval, you would probably, I'm going to just mark where you're measuring your PR intervals. If you didn't notice that they're greater than 0.20, then you would miss that it is a first degree AV block. Your QRS is normal because it is still coming from the atrium. The causes of first degree AV block: increased vagal tone. Sometimes drugs are blocking, such as beta blockers and calcium channel blockers, which are given for patients who are in AFib or aflutter to decrease or slow down the conduction through the AV node. Sometimes the patients who are on beta blockers or calcium channel blockers for blood pressure may have a slowing of that AV node to the point of developing a first degree AV block. Also digoxin and amiodarone. Other things that can cause a first degree AV block is degeneration of the conduction pathway associated with aging. So the AV node just slower conduction through to the bundles of His. Hyperkalemia is another thing that can delay that or cause a delay in the AV node to go down the bundles of His. And an inferior wall MI. We talked about sinus bradycardia can occur in inferior wall MI, but again, your inferior wall of your left ventricle is supplied by your right coronary artery, and that right coronary artery also supplies the SA and AV node, and patients can develop AV blocks when they're having an inferior wall MI. The clinical significance: usually your patients, if they're asymptomatic, it's not a problem. You may not notice it, but it can progress to a higher degree block. The treatment, usually there isn't any unless the patient is showing signs of bradycardia, because oftentimes you will see a first degree AV block in a bradycardia. But again, you wouldn't, if it is new to the patient, you might want to do a medication reconciliation, identify what would potentially be causing the AV block, and monitor that patient to make sure that they do not progress to a higher grade AV block. In second degree AV block type, 1. We also may call it Mobitz 1, and some people may call it a Wenckebach. One of the things you're going to see is these terms are all interchangeable. They are all in common use. So you may hear second degree type 1, second degree Mobitz 1, or Wenckebach. They all mean the same rhythm. So this is a higher degree block, and what you're going to notice with this one is that you do have P's, but you have extra P's. So as you'll notice, there's 2 P's to that QRS, and there's 2 P's to this QRS. So now you have a higher grade block. In first degree AV block, you have a P for every QRS. It is just a delay between the SA node firing and the AV node allowing that conduction to go down the bundles of His. In type 1, some of the sinus impulses fail to be conducted to the ventricles. And the hallmark of this defect is the successive lengthening of the PR interval until one of the impulses fails to conduct. So when you're measuring your PR interval, and you're measuring all of your PR intervals, you'll note that they are getting longer, and then there's a drop. And it's almost like they develop what they call a pattern. And again, they are not constant, they are not the same until you get a drop. So they are lengthening or getting longer, and then dropping. That is the primary characteristic of first degree or second degree type 1. The Wenckebach pattern can occur over any number of complexes, as you can see. And we're looking at this page 149, 820. What you're going to find is the rhythm, your atrial rhythm will be regular. Your ventricular will be irregular. So your P waves are doing, there's not a problem, with the atrial or the SA node. It's firing, it's doing its thing, and if you map it out, it will map out. It is where the R waves are coming in, the conduction going down is varying and giving it an irregular rhythm. So second degree type 1 or Mobitz 1 has an irregular R to R. The atrial rate is going to be faster than your ventricular rate because there's more P's than QRS. And again, you can determine your atrial rate by going P to P and counting the boxes, and you can use your small box conversion table to see. Your ventricular rate obviously will be less than your atrial rate because of those dropped beats. You do have P waves, they're all coming from the SA node. Again, to remind you, the SA node is not the problem. It is the AV node that is the problem, that is delaying or blocking the conduction down. So your PRI varies, progressively lengthening until the beat is dropped, and after the beat is dropped, the PR interval will shorten again, and then lengthen pattern will reoccur. Your QRS is normal because it is coming from the atrium. Here's another example of second degree type 1. So as you can see, the P waves are marching through. You have arrows that are identifying the P's. If you were to measure your PR intervals, they are getting longer, even if it's by just like a couple boxes, and getting longer and longer until you have a dropped beat. So the key thing to remember with your second degree type 1 is that your PR interval is not constant, and your PR your R to R will be irregular because it is, especially because it has a dropped beat. So the causes of a second degree type 1 or Mobitz 1, common again in an inferior wall MI, and it usually is transient. It will disappear once the patient has reperfusion. Oftentimes, again, those drugs that decrease or slow down the conduction through the AV node, such as DIG, beta blockers, and calcium channel blockers, we would do a medication reconciliation. And other things such as increased vagal tone and hyperkalemia also can develop a second degree type 1. The clinical significance, usually none unless there's underlying rate of bradycardia, and it can infrequently progress to a more advanced block. So your management, usually there's nothing that's required unless there's a bradycardia that's become symptomatic, and then therefore you would use your bradycardia algorithm. And again, when you're looking at what medications are on, medication reconciliation, you would want to identify any medications that might be causing it. So second degree type 2 or Mobitz 2, it again has more P's than QRS's. And what happens in type 2 AV block or second degree type 2, there's a failure to conduct some of the sinus impulses. And in type 2 block is different in its location and its severity. The location of the conduction defect is below the AV node at the level of the bundles of His, which would cause a narrow QRS, or most commonly at the level of the bundles of His, which would give you a wide QRS. So you may have varying QRS width depending on where the location of the conduction defect is. Your P waves are present, they're regular. The SA node is not the problem. The other thing is the PR interval may be either normal or prolonged, but the key thing is that it's always the same, meaning that your PR interval is constant. So all of your PR intervals, PRIs, if you measure them out, you only measure PRs that has a P and an R because there's no PR here you need an R. So measuring all your PR intervals, they are primarily constant or the same. That is the key thing to remember about second degree Mobitz 2 or type 2, that your PR is constant. It is not constant in second degree type 1 because it's prolonging. And second degree type 2, it's going to have more P's than QRS's, but what you're going to see is a constant PR. It might be normal or it might be prolonged, but they are all the same. The R waves are regular unless the conduction ratio varies, such as in this strip, you could have either an irregular rhythm or a regular rhythm. This R to R is demonstrating an irregular rhythm because you have 3 P's to this QRS, and you have 2 P's to this QRS, and you have 2 P's to this QRS, and 2 P's to this QRS. So this is giving your R to R an irregular pattern. But if you had a constant 2 P's to every QRS, you would have a more regular pattern. So your R to R's can be either irregular or regular. Whereas second degree type 1, your R to R's are always irregular because of that dropped beat. The rhythm, as I said, your atrial rhythm is regular, and it's regular with all your AV blocks because your SA node is firing without a problem. Your ventricular rate can be regular or irregular, and in this example, you have 2 P's to every QRS, which now is going to give this a more regular rhythm. The R to R is considered regular. But if you had a different variation in how many P's to QRS, that's going to give you an irregular rhythm. So second degree type 2 can be 2 ways, irregular or regular in the R to R. The rate, the atrial rate, is going to be faster, and that's your underlying rhythm, such as it might be going at a rate of 70s. Your ventricular rate is going to be less because due to the atrial has dropped those beats, so you have more P's than QRS's. Your P waves are all sinus, and again, the PR interval, if you're looking at your PR interval, they are all the same. They are constant. This is the only high-grade AV block that has a constant PR, and I can't stress to you enough to remember that. That's something to memorize. Your PR interval is constant. And your QRS's may be normal if it's blocked at the bundles of His, or it might be wide if it's blocked in the bundles of His. So, or below it, I should say. Here's another example of second degree AV block type 2. The problem is you now are getting even a higher grade AV block where you have 3 or more P's to a QRS. And again, you can see you have P waves and your PR interval is constant, but you have more P's than QRS's. And again, they're pretty much marching along doing their own thing, but your PR is constant and your P's are regular. This is showing a regular R to R. And again, your PR is constant in a second degree type 2, Mobitz 2. And your R to R can be either irregular or regular. It's the only one that can be either one, irregular or regular. The causes of your second degree AV block oftentimes would be more of a anterior wall MI, where that's a higher grade because your anterior wall is supplied by your LAD, which supplies your bundles, and you can have a block that's decreasing the impulse down the bundles of His. So that can cause that from an anterior wall MI. Other things, acute myocarditis or degenerative disease of the conduction system, such as age-related. So as we get older, our conduction system sometimes doesn't work as well, and therefore those patients would need a permanent pacemaker. Again, it does have potential. Second degree type 2 is considered life-threatening because it has 2 potential worsening of the block, where it could go into complete heart block, or it could go into what we call ventricular standstill with little or no warning, where you'll have just a rhythm of P waves and there'll be no QRSs. So as there become more QRSs are being blocked, it's going to give an indication that you potentially could be going into ventricular standstill. So second degree Mobitz 2 is a life-threatening rhythm. Your management is usually going to be your bradycardia, symptomatic bradycardia management, if they're symptomatic. Because the block is below the level of the AV node, atropine may not be effective. You probably will need an external pacemaker to be more immediate, but you are going to still follow the algorithm for bradycardia, which would be atropine 0.5 IV or IO, and apply a transcutaneous pacing. You can try some dopamine and epinephrine infusion to increase your ventricular rate, and eventually, if it's not transient, you would possibly have to do a transvenous pacing and determine whether that patient needs to have a permanent pacer. In third degree heart block, there is complete loss of conduction between the atria and the ventricles. The atriums are doing their own thing, they are regular. The QRSs, or your R to Rs, is regular because your ventricles are doing their own thing. So you have 2 different types of looking third degree heart blocks. Your QRSs in the top one are normal or narrow because what has happened is your SA node is firing, it's not going down, but what's happening is that the junctional pacemaker is supporting the rhythm. So that's why it's going to produce a narrow or normal QRS. But your SA node is firing, but that conduction is not getting down the AV node. So it's coming from the junction, which is sending that message down the ventricles. And that is causing the bundles of His at the same time, so therefore it's going to produce a normal QRS. In the bottom one, it's slower because, again, there's no communication between the atriums and the ventricles, so therefore the backup pacemaker kicked in is the ventricles, and because the ventricles will fire at a slower rate as a backup pacemaker, usually 40 or less, you're going to have a wider QRS and a slower R to R. So in both of these, you can see that there is P waves that are marching along, doing their own thing, and what you're going to also see is there is no communication between the P's and the QRS's. But again, in all of the blocks, your P to P is going to be regular because it's not the SA node that is the problem. So again, your PR interval these PR intervals are all over the place. They are not constant. And you're going to look at all of them, and again, they look almost like they're progressing, but remember, the difference is this is third degree AV block. The R to R is always regular because your R to R, your ventricles, are doing their own thing. In second degree type 1, you are dropping beats, which makes them have an irregular R to R. And in this one, you have your P waves that are just marching along. Your PRIs are varying all over the place or not constant. So there's no relation between the PR to P to the Rs. So there is no correlation. And again, you may have a narrow QRS or you may have a wide, depending on which backup pacemaker kicks in, whether it's your junctional or your ventricular. And remember that the atrium is independent of itself, and the ventricles are doing their own thing, so there's no communication between the P's and the QRSs. So in this one, your rhythm, your atrial will be regular, and your ventricular is regular. Always regular. Your R to R is always regular. Your atriums, your P to P is regular. So you can map them right out. But again, you can do that in all the higher grade blocks. The rate, your atrial rate is going to be usually sinus and faster than your ventricular rate. You have more P's than QRSs. And your ventricular will be either, if it comes from the junction, it might be 40 to 60, where if it comes from the ventricles, it'll be 40 or less, and it'll be wider. You have P waves, they're all sinus because your SA node is firing. Your PRI is not constant because it's not related to any of the QRSs, so it appears that they vary greatly and are not measurable. And again, your QRS, if it's narrow, it's coming from the junctional pacemakers have taken over, and if it's wide, the ventricular pacemakers have taken over. And your third degree AV block is usually caused by an acute MI, digitoxicity, and oftentimes I've seen Lyme's disease patients who are young men, very athletic, and you would think that their heart rate would be low anyway, but all of a sudden they have either complete heart block because Lyme's disease can cause a carditis and can interfere with the conduction. So again, you would treat the Lyme's disease, potentially maybe have to put an external pacer on if they become symptomatic. But again, you can treat them with the Lyme's disease, and once that resolves, the complete heart block will go away. It also may be permanent in older patients with degenerative disease and conduction system and may require a permanent pacemaker. So it is serious, and it is considered one of our lethal rhythms because it can progress to ventricular standstill without warning. And usually these patients are bradycardic, and if they are not, or if they're stable in the beginning, they could easily progress to unstable. We still are going to treat them in a Brady algorithm. You would give them atropine. If they're unstable, you give them atropine 0.5 IV or IO and prepare for transcutaneous pacing. You can do dopamine or epinephrine drips, and eventually you might have to do transvenous pacing. If the patient is not symptomatic, it wouldn't be a bad idea to put a transcutaneous pacer on standby and have it prepared so that if needed, this patient could have, the pacemaker could be turned on if the patient becomes unstable. And atropine, again, it probably won't be effective because it's only increasing the SA node, just like in second degree type 2. But again, you're going to follow the algorithm when you have an unstable bradycardia. This reference is on page 154. And there's different ways that we are teaching you how to remember the AV blocks. It's one of the hardest rhythms that people struggle with, is how to remember. So this is just a little algorithm if you want to use it. we'll show just a variety of ways that you can adopt. Whichever one works for you is what you would use. So if you're looking here, so if you have more P's than QRS's, if you do not, and your PR is greater than 0.20, you have a first degree because your first degree AV block has 1 P for every QRS. If you do have more P's than QRS's, then you look at the PRI. Is it constant? Yes, then we know that it's a second degree type 2. If the PR is not constant, then we would look, is the R to R regular or irregular? If it's regular, it's third degree AV block. If it is not regular, then it's second degree type 1. So this is one way you could use to try to remember which block is which. Just to put them side by side, so in a first degree AV block, there's 1 P for every QRS. The difference is the PR interval is the same and it's prolonged. So it's constant, but it's prolonged. And there's, again, 1 P for every QRS. In second degree type 2, your R to R is irregular and your PR is not constant because it's prolonging. In second degree type 2, your R to R can be two ways. It can be irregular or regular depending on how many P's to each QRS. The one key thing to remember with second degree type 2 is that your PR interval is constant. In third degree AV block, your R to R is regular and your PR is not constant. So the PR is varying for there's not measurable for your PR interval because it's independent, their atrium is independent to itself than the ventricles. There's also a heart block boogie if this is something that you want to remember. If your Q's are far from P's, then you have a first degree. Longer drop, then you have a Wenckebach. If your P's just drop some Q's, then you have a Mobitz 2. When your P's and Q's don't agree, then you have a third degree. I can never remember this boogie, but if that's something that you want to remember, that's fine. Again, you can adopt whatever way works for you. This is another way, so it's process of elimination. So on the top, I'm looking at what your P to P is, what your R to R is, and what your PRI should be. So in a first degree AV block, you have P to P's are regular, and obviously you can see that they're regular throughout all of the AV blocks. Your R to R is regular in a first degree AV block, and you have 1 P for every QRS. The one key thing is that your PRI is prolonged, greater than 0.20. In second degree AV block, your PP is regular, your R to R is irregular, and your PRI is not constant because they keep getting longer and longer before it drops. Second degree type 2, your R to R can be either irregular or regular, but your PRI is constant. It's the only one of the higher grade blocks that has a constant PR. And then your third degree AV block, your R to R is regular and your PRI is not constant. So let's make this a little bit easier. So first degree AV block can be interpreted as normal sinus rhythm or sinus brady, depending on the heart rate. But if you don't measure your PRI, you're not going to note that it's prolonged or greater than 0.20. So always measure your PRI when you're doing your rhythm analysis. And in this little blocks, if you have more P's than QRS's, now you have a higher grade block. So that's when you go secondary type 1, your R to R, is it regular or irregular? So it's always irregular. Your PRI is not constant. In second degree, type 2, it can be two ways. It can be irregular or regular. And the PRI is always constant. Remember, this is in a higher grade blocks when there's more P's than QRS's. And third degree, your R to R is always regular, and your PRI is not constant. So let's make it even simpler. I kind of say this is a quick reference sheet once, kind of from the previous slide. And once you understand it, you can go 1, 2, 3, I, R, R, for I for irregular, R for regular. And then the PRI constant It is not constant or negative in second degree type 1. It is constant in second degree type 2, and it is not constant in third degree heart block. So this is just a process of elimination, and when we do is we can practice them. So I usually look at if I see more P's than QRS's, I look at my R to R. Is it irregular or regular? And right off the bat, you don't even need calipers to determine it. If it's irregular, I know it is not third degree heart block. Then I look at my PRI. If my PRI is constant, then I know it's second degree AV block. If the PRI is not constant and the R to R is irregular, then I know that it is a second degree type 1. Same thing if I look at my R to R and it's regular. If my PRI is not constant, then I know it's a third degree AV block. If it is constant, I know it's a second degree type 2. So second degree type 2 can be two ways, I, irregular or regular, and it's the only one that has a constant PR. So don't forget to check those PR intervals. So at this time, I'm going to have you pause the video and do this work. Do 8.3, 8.10, 8.15, 8.24, and 8.32, which has a scenario with it, and 8.77. And then practice these and see how you do with your AV blocks, and then we'll come back and then turn the video back on and we'll review what you did. All right, so I added the little cheat sheet in the bottom of this strip. So first and foremost, we look at the rhythm. Is the rhythm regular or irregular? So your atrial rates are regular. Again, your atrial rate is a rate of like 94. So your R to R's are regular and your atrial rates are regular. So your ventricular rate is 32. You have 3 P's to QRS's because there's some P's that are hidden in the T's. Your PR interval. If you're looking at your PR interval, they're pretty constant. They're pretty much the same. Again, measuring from the P to the R, and I see about 3.5 to 4 boxes, which we would consider constant. So you have a PR interval of 0.14 to 0.16. Your QRS is, I'm going to check that for you. So it's a little bit wide. So we measure from the beginning of the QR I guess, into the S. So it looks like about 3 boxes. So your QRS is about 0.12. Now don't forget if you did a QT interval, so I'm going to measure from the beginning of the QRS to where the T wave comes down. And it's pretty long. It's like 17 boxes. So you're, so you're measuring all the way to the end of the T, which is about 0.68. And again, there's P waves hidden in those T waves. So going back down into my little AV block, so the R to R is regular, so it cannot be a first degree AV block. Then I look at my PR interval. Is it constant? Yes, it is constant. It is regular, and so therefore it is a second degree type 2. So if you interpreted this rhythm as a second degree type 2, you were correct. And it has a 3-to-1 conduction block. All right, so on 8.10, this rhythm, if you look at it, is regular. So your R to R's and your atrial rate is about 75. Again, if you were to determine what your atrial rate is, you go from P to P and you count how many boxes in between, and it came to 75, we figured out. Your ventricular rate is 30, and you have about 2 P's to every QRS, and they are sinus. And you have a PR interval, so you measure all your PR intervals. And your PRI is pretty much the same, 0.20 to 0.22. So that's considered constant. Your QRS, so you're measuring from the beginning of your QRS to where it comes back to the isoelectric line. You have about 2 to 2.5 boxes, looks like. So your QRS is 0.08 to 0.10. Your QT interval, this is hard because it kind of difficult because your P is getting up there. So I'm going to take one that looks like maybe it might go to there. So you would count how many. And I believe there is, it's saying about 4, so maybe 12 or 11, 12 boxes. With that, let's use our cheat sheet to determine which block it is. So your R to R is regular, so it cannot be a first degree, second degree type 1. And it can't be first degree because there's more P's than QRS's. So then we look at the PR interval. They are constant, so it is second degree type 2. So if you again interpreted this as second degree type 2, you would be correct. In this one, you're looking, your R to R is regular, and then your rate is 84 because it is a regular rhythm. And again, if you did your 6 seconds, and just because I'm going to show you again, so you have 1, 2, 3, 4, 5, 6, 7, 8. So the heart rate is about 80, but more exact is it's 88 because you have a regular R to R. You have sinus P waves, and then you measure your PR interval. And let's see, your PR interval is pretty long, so it's definitely over 0.20, so it looks like it's 0.24 to 0.28. So you have a prolonged PR, but it is constant, it's all the same, and you only have 1 P for every QRS. Now your QRS complex, you have beginning, and again you kind of have to come up. It looks like about 2 boxes. So that would be 0.08, some are a little bit less, maybe 1.5 boxes. So again, 0.06 to 0.08. And so your QT interval, you measure from the beginning to the end. It looks like about 10 boxes, so about 0.40. And our interpretation of this rhythm is, because it's not a higher grade block, so we don't even need this chart down here. So it is a sinus rhythm because it came from the SA node, and because your PR interval was prolonged, we are going to call this a sinus rhythm with a first degree AV block. Other things you might want to note is if you're drawing a line across your isoelectric line, your STs are below that. So we would want to make note that you do have ST depression. All right, so 824. So in looking at this R to R, this rhythm is, it looks like it's regular and then it becomes irregular here. So we're going to call it irregular. Your atrial rate is faster because it has an extra P in here. And you have, let's see, so your all P waves are sinus. Your ventricular rate, I think we determined it's 60 because again, you want to go between your R waves, your 6 seconds, and so you have 6 complexes, so we're going to say the heart rate's about 60. Your, let's see, your PRI, so measuring your PRI, so you go through and you measure all your PRIs. I'm measuring them all, and they looked pretty constant until it looks like this one's a little bit longer, and then you have a dropped one. Then you go have this pattern, and the next one is longer. So these are not constant. Your PRI is between 0.28 to 0.36, so they are not constant. Your QRS, let's measure that. Your QRS, you're measuring from the beginning of the R wave to where the S wave comes up. It looks like about 2 boxes, so it would be 0.08. Just checking other ones. Whoops. Yeah, they look about 2 boxes. And your QT interval, it's real hard to see because it's almost like it's hard to see whether it's coming up. It looks like about 10 boxes. Is it going all the way to the T? So it's real hard to do your QT interval. But let's look at what I would say it's probably 5. Oh, maybe not quite 10. So maybe about 7, 8 boxes. So it looks like about 7, 8 boxes. All right, so now let's determine. You have more P's than QRS's, so we're in our higher degree, so we're going to use our boxes. So my R to R is irregular, so I cannot use, it will not be a 3rd degree AV block because your R to R is irregular. So then I look at my PR intervals. Are they constant or not constant? They are not constant, so therefore it would be 1st degree or 2nd degree type 1. So this is AV block type 1, 2nd degree type 1. And because you have a prolonging PR and it is not constant and the R to R is irregular. All right, so this person, has a scenario with it. So your person is Mrs. J, a 72-year-old female, is brought into the ED after having passed out in church. She's complaining and feeling dizzy and lightheaded. Her blood pressure is 70/50. She's pale and diaphoretic. So in this instance, you put her on the monitor. You see this rhythm. It looks like a bradycardia. So because she's unstable, you're going to follow the bradycardia algorithm. And then you can look and determine what rhythm it is. So the R to R is regular. So the rate, it looks like it's about 30s, low 30s. And your P waves are going along, they're regular. Your PRIs are all over the place. So if you're measuring your PRIs, it's really not, they're not connecting. They're not constant. So your PR is not constant. Your QRSs are wide. So it looks like about maybe 3 to 4 boxes. So your QRS is wide. So we're going to determine in your QT, if you can figure out what comes down, it's pretty long. It looks like about actually almost 14 boxes, and multiply that by 0.04. So let's determine what this rhythm is. Let's go to our cheat sheet down at the bottom. So the rhythm is regular. The R to R is regular. So it can't be 2nd degree type 1. Then we look at your PR interval. It is not constant, so it cannot be 2nd degree type 2. So it would be 3rd degree AV block. Again, your PR interval is not constant and your R to R is always regular with a 3rd degree AV block. In this rhythm, the rhythm is regular and your atrial rate is 94 and your ventricular rate is 44. You have more P's than QRS's. And let's see, your PRI. So you have, looking at your PRI, they are not constant. They are all over the place. Now, if you were to look at this, you say, oh, my PRI looks like it's getting longer and longer, right? It does. It's just how it works out. So, but let's look at our block. So many people would think, oh, because the PRI is getting longer and longer, that means it must be a Wenckebach. Nope. Take a look. In Wenckebach, your R to R is always irregular, so it cannot be a Wenckebach or second degree type 1. The PR is not constant, so it cannot be second degree type 2. So it can be, and it is, third degree AV block. So don't be fooled. Always make sure you check the R to R, if it's regular or irregular, and check the PR interval. And these QRSs are very wide, so it looks like they're about almost 4 boxes. And that would mean that it's probably coming down by the bundles of His, so it's the ventricles that are kicking in. And of course, the heart rate's very slow in the 40s, so that would indicate that it's probably coming from the ventricles. And this is a third degree AV block. Now for your TS or QT interval, that looks like about 12 boxes, so it would be 0.48. All right, that concludes AV blocks. Hopefully you can practice using the cheat sheets or whichever way you feel that is easier for you to remember. And then you do your homework, and then the next session you will get to practice your AV blocks.